For our next talk, we are pleased to have Dr. Harvey Hecht, returning to California, from New York, where he is the Associate Director of Cardiac Imaging at the Mount Sinai Hospital and Mount Sinai School of Medicine, where he is also a professor of medicine. Harvey will talk to us about a planned NIH study comparing shape with the status quo. Harvey.
Thank you, Dan. Up front, I promise to be not controversial, but I reserve the right to editorialize. So my first question is, do we need an NIH randomized controlled trial? And Matt showed this before about Scott Grundy's wisdom, the 3 virtues of imaging. I'm not going to repeat them. This is the final one, but this is a comment that I made, again, 2003. The most important role of risk factors may be to identify the modifiable targets of risk reduction in patients with risk already established by clinical events or significant coronary artery calcium, and I think that still holds true today. I don't need to belabor the power of coronary calcium. Everybody knows it. That's one of the reasons we're here. That's the foundation of SHAPE. And these are the numerous studies, and I don't know of no other area in medicine in which the results have been so uniform and so positive. In every study, coronary calcium has been superior to and significantly added to the area under the ROC curve for all risk factor-based analyses. On the basis of that, including some data, actually, except for some data that had not yet been published, in 2006, under Dr. Nagavi's leadership, the first SHAPE guidelines were produced, in which elder people received a pass, as did people who were very young, mainly people who had very low risk, which meant 0 risk factors. And then atherosclerosis test, coronary calcium or IMT was recommended, with distribution to either positive or negative tests, and further distribution to risk levels depending upon the result. I should add that these coronary calcium criteria are basically wrong, and I'll show that to you. Coronary calcium less than 100 is not moderately high risk. All of these, at least most of these, are wrong, and I will correct them for you. So in 2010, as Matt showed, we have guidelines already. It's reasonable for intermediate risk, 10 to 20% 10-year risk, may be reasonable for patients at low to intermediate risk. So even without randomized controlled trials, we have as strong a statement as we can reasonably expect to have. Will it ever be a class 1? I doubt it. There's very few things in this world that are class 1. We also have the appropriate use criteria in 2010, which says that it is appropriate to do coronary calcium scanning in the intermediate risk category, as well as in low risk but having a family history of premature coronary disease, and in the high risk category, very interesting, uncertain, which specifically they go to great pains to point out, does not mean that you should not do the test. It means that it's uncertain. So even without an RCT, we've made tremendous progress. And if we compare the guidelines from 2010 with the SHAPE guidelines, high coronary calcium score, high risk patients are not really addressed by the guideline. In SHAPE, it's a class 1 indication. Intermediate risk is 2A. Everything in SHAPE was class 1, really. Low to intermediate risk was 2B. Lower risk was class 3, except for those patients who had a family history. And SHAPE said, yes, we can do it, especially if there's a family history or diabetes. SHAPE provided treatment guidelines, the ability to both downgrade and upgrade risk. ACC statement did not provide treatment guidelines, and although they were not explicitly stated that you could downgrade or upgrade risk, the implication was that you could certainly upgrade the risk. But, of course, we demand outcome studies. Stubborn resistance. Never underestimate the power of people who cling to each other to perpetuate the status quo. So it's clear that everything we've accomplished so far, in the minds of some, has not been enough. Editorial that I published in 2008, if neither the calcium score nor the Framingham risk score has outcome data to support it, and that's true, why not use the one with a greater prognostic power? Especially since there is no contest between coronary calcium and the Framingham risk score. It is incumbent on the cardiology community to temper the inflexible need for randomized trials with the reality of 500,000 people presenting with an MI annually as their first symptom, 95% of whom could be identified as high risk by coronary calcium and aggressively treated to significantly reduce events. Aha! The naysayers would say, how do we know that it will result in a reduction of events? We still don't have the outcome data. Well, here's an analogy. This is actually published in the British Medical Journal in 2003. Parachute used to prevent death in major trauma related to gravitational challenge, systematic review of randomized controlled trials. And here's a picture of it. Conclusions. As with many interventions intended to prevent ill health, the effectiveness of parachutes has not been subjected to rigorous evaluation by using RCTs. Advocates of evidence-based medicine have criticized the adoption of interventions evaluated by using only observational data. We think that everyone might benefit if the most radical protagonists of evidence-based medicine organized and participated in a double-blind, randomized, placebo-controlled crossover trial of the parachute. So is that a joke? Well, not really. Let's look at this. These are high-risk states, jumping from an airplane and high coronary calcium score. The treatment for jumping from an airplane is to use a parachute. The treatment for high calcium score is aggressive medical treatment. Now, if we did an RCT showing that a parachute did not reduce the events, the mortality from jumping from an airplane, this does not negate the value of identifying jumping from an airplane as a high-risk event. It would just mean we need a better parachute. So randomized controlled trials are not necessary to prove that treatment of high-risk patients saved lives. If a randomized controlled trial were performed and failed to show that treatment of calcium-identified high-risk patients saved more lives, the fault would lie with the treatment rather than with the test. And this is what has been emphasized over and over again. We have to treat the patient more effectively. We do not have the tools now, I think, to have effective treatment. We know that the statin monotherapy trials, 30% reduction, that's terrible. All of this points out how little we understand. So, to reiterate again, even without the RCT, what more can we accomplish than having achieved this guideline and this guideline? Okay, let's talk a little bit about data and hold the editorializing for the moment. Coronary calcium absolute event rates in asymptomatic patients. This looks at 5 of the major studies: St. Francis, the Becker study, MESA, HNR, and Rotterdam. And if you look at the event rates, annual event rates, to different characteristics of coronary calcium, different group, without going through each one, I'm going to summarize it for you. Zero calcium score is very low Framingham risk. 10-year event, 1.1 to 1.7%. 1 to 100 is low risk, 2.3 to 5.9%. 100 to 400 is intermediate risk, period. It's not high risk. In the past, everybody has said greater than 100 is high risk. That's because they're lumping in everything greater than 100. But if you look at 100 to 400, it's intermediate risk by Framingham equivalence. Greater than 400 is high risk, and greater than 1,000 is very high risk. This is the reality of the coronary calcium risk groups. Looking at all the net reclassification indices from 3 major studies, MESA, Heinz, Nixdorf, and Rotterdam, it's really remarkable how consistent these findings are. If you look at the NRIs for MESA, 25%, 22.4 for Heinz, Nixdorf, 19% for Rotterdam. Let me go back one here. And if you look at those percentage of low-risk patients that are reclassified, 11.6, 15%, 12%, very consistent. See, the MESA, what they did was they lumped the 6 to 10% along with 10 to 20, so they looked at the 6 to 20%, 54%, 10 to 20, 66%, 10 to 20, 52%. High risk, 36%, 34%, 34%. Incredibly consistent. This paper is a very important paper. This was from MESA, distribution of coronary calcium by Framingham risk score in MESA. Prevalence of greater than 0 was only 46%, more than half had a 0 score, greater than 100, 21%, greater than 300, 10%. And if you look at the number needed to screen in each of the Framingham risk categories to find a patient with a calcium score greater than 300, well, in the very low risk groups, sure, 60 patients, 23 patients. But you go to 5 to 7.5%, only 13 patients. Go to 7.6 to 13%, only 8 patients. Intermediate risk, 6.4, 4.2. And look at the high risk group. You only have to screen 3.3 patients to identify a patient who is truly high risk on the basis of their coronary calcium score. So I don't understand why we exempt high-risk patients from being downgraded by coronary calcium. I'm going to talk about that. People say, well, high risk by Framingham is sacred, it's sacrosanct, we can't touch it. This paper just came out in Cert Cardiovascular Imaging, 44,000 asymptomatic patients, 6-year follow-up. These are the risk factors, and the endpoint was all-cause mortality. And here, for example, if you look at patients with 0 risk factors, calcium score greater than 400, 17 events per 1,000 person years, 3 or more risk factors with a 0 calcium score, less than 3 events. And if you look at this bottom line here, looking at patients going from 0 risk factor up to 3 or more with a 0 calcium score, yes, there is an increase, but what is the extent of that increase? 0 calcium score with 0 risk factors, 5-year all-cause survival, it shouldn't be mortality, 99.7, 1 risk factor, 99.3, 99.3. With 3 or more risk factors, still, the survival is 99%. So even if there is a small risk attributable to having a 0 calcium score with multiple risk factors, it's a minuscule risk. And yet we are so reluctant to downgrade presumably high-risk patients. And if you look at the survival curves here, with 0 risk factors, 1, 2, and 3 or more, 0 calcium score is just about flat for every one of them, with everything else decreasing according to the number of risk factors. In fact, these observations are really extended to young patients in the CARDIA study published in JACC Imaging this year, 2,800 patients aged 33 to 45. And in those who had a Framingham risk score greater than 10, which is pretty hard to achieve in this age group, 17% had a calcium score greater than 100, and the number needed to screen was only 6. Editorial, I think written by Dan, suggested that a greater than 5% Framingham risk score cutoff should be used, an even more aggressive approach to screening younger people. So let's go to the NIH trial, which is really based upon a slide set that Matt Budoff, who was originally supposed to give this talk, gave me. And this is as of February 16, 2011. There is no more available public data as far as he knew. The background was that coronary calcium known to predict events. Beyond Framingham risk score, it's increasing. The value of coronary calcium to enhance prevention is unknown. The costs are potentially great. Risks small, but real. So we need a trial of coronary calcium to inform CHD prevention. I want to briefly focus on these 2 points here. Costs. This is a study published by Diamond and Call in 2007, addressing 3 treatment strategies: treat everybody, treat by NCP3 guidelines, and treat by the SHAPE. And they concluded that the cost per life year extended was least for NCP guidelines, and SHAPE and treat all were approximately the same. But this was based upon a calcium price of $400, which is basically non-existent. I know we charge $100 now, and that's becoming the norm. If you recalculate that using simple arithmetic, $100 price, look how cost-effective coronary calcium is compared to the others. And then if you compare SHAPE versus NCEP, for instance, SHAPE would be more expensive, $32,000 per life year saved. Treat all turns out to be the best, but again, that's at $400. If you do it at $100, SHAPE is far and away the most cost-effective. Radiation. I wish every person who complains about radiation would read this. The American Association of Physicists in Medicine acknowledges that medical imaging procedures should be appropriate and conducted at the lowest radiation dose. Discussion of risks related to radiation dose for medical imaging procedures should be accompanied by acknowledgement of the benefits of the procedures. Here comes the message. Risks of medical imaging at effective doses below 50 millisieverts. We're doing calcium scanning. My wife had one the other day, 0.3 millisieverts. We're getting it lower. Effective doses below 50 millisieverts for single procedures or 100 millisieverts for multiple procedures over short time periods are too low to be detectable and may be non-existent. Predictions of hypothetical cancer incidence and deaths in patient populations exposed to such low doses are highly speculative and should be discouraged. Okay, back to the study. Is a coronary heart disease risk management strategy guided by the coronary calcium score associated with fewer events than usual care among individuals who are at relatively low risks, specifically in a population with 10-year risk of 5 to 10%? Does treatment of calcium-positive persons with statin therapy lead to fewer events versus usual care? Age criteria, greater than 45 for men, 55 for women, asymptomatic, no disease, not on statins. And this was the population. Asymptomatic men and women with Framingham risk score 5 to 10%, plus an LDL less than 160, because they would not let patients with LDL greater than 160 go untreated. They apparently were considering adding intermediate risk patients, but lowering the LDL bar to less than 130 or less than 100. Okay, the intervention. In the intervention group, for a coronary calcium score of 0, no medication. For coronary calcium score greater than 0, statin recommended, depending upon the score, 40 milligrams for less than 100 calcium score, 80 milligrams for a score greater than 100. Primary outcome, major events, composite CHD events, including revascularization, similar to MESA, and these were the secondary endpoints here. All of them are very worthwhile. The assumptions, which of course are critical, based upon the Framingham risk score, conditional distribution of calcium score by Framingham risk score was based upon the MESA study, as were the event rates by calcium score, statin dose distributions from the literature, and effect sizes for statin treatment from the literature, racial breakdown similar to MESA. So the assumption was, based on the literature, that there would be a 22% event reduction with both 40 milligrams of Lipitor and 80 milligrams. The risk score distribution, less than 5% of the patients would have 8.5% of the patients would have a very low Framingham risk score, 85% in this category. I'm not quite sure I understand these numbers. That seems a lot higher than I would have thought. But this is the slide set that was given to me. Only 8% in the 10 to 20% category. Distribution of calcium scores is critical. In the proposed test group, 50% would have a 0 calcium score. 30% would have a score from 0 to 100, and only 21% would have a score greater than 100. And these were the projected event rates, 10-year event rate for a 0 score. I don't know where this comes from. I'm sorry, it's 1.6%, that's correct. For the intermediate, for the 0 to 100%, less than 100, 0.48% per year, which is correct, but that doesn't translate to 1.3% 10-year rate, but again, that's the slide set. And statin dose distributions, we don't have to go over. Significance level, dropout was estimated to be 2%. This is important. 2 years to recruit, 6 years to do the study. That's 8 years. Sample size, 21,000 for 80% power, 28,000 for 90% power, $60 million. A lot of money. So let's say we do the study, and let's line it up with what we already have. Guidelines and shape. Will it give us any information about the high-risk group? No, not addressed. About the intermediate risk group? No, unless they do add a substantial number from the intermediate risk group. I have no idea if they intend to. Low to intermediate risk group, that's the group they're targeting. What the results will be, we don't know, to be determined. Lower risk group, no information whatsoever. That's not being addressed. Will it contain treatment guidelines? Will you be able to downgrade or upgrade risk? I don't really know. So, since about 50% will have a 0 calcium score and will contribute very few events, it may be very difficult to demonstrate a positive result. So the powering of the study is crucial. I suspect that it's going to end up being underpowered because of this factor. Okay, let's say you do it. After 8 years, that's 2020, and $70 million, a positive result will reinforce coronary calcium use only in the low to intermediate group, unless the intermediate group is added. So if you did that, the usual complaints from the RCT and from the guidelines, but there are no outcome studies for high, intermediate, and low risk groups because all you addressed was the 6 to 10% group. So you're sort of stuck no matter what you do. It's very hard to win this battle, and why wait 8 years to try and prove something in small part when the much greater sum of it is already in the guidelines. SHAPE is not only about coronary calcium, though. It's about carotid as well. So let's talk a little bit about carotid ultrasound. In the SHAPE 1 guidelines, carotid IMT plaque was accorded a class 1 criteria, high risk, and then it's intermediate here for the ACCHA guidelines. CRP as class 2A indication. SHAPE called it intermediate risk. Forget about it. Let's not even talk about CRP anymore for risk prediction. There's never been a single study that showed that it added to the area under the ROC curve for conventional risk factors. Okay, so let's not even talk about CRP. I'm glad you all agree. IMT, I think, has also really had it, as Tasneem suggested. If you look at the recent meta-analysis, the addition of IMT to the Framingham risk score was associated with small improvement in 10-year risk prediction, but this improvement is likely to be of clinical importance. So we're really talking now about plaque burden. And I'm going to show you some of the data from the high-risk initiative. 61,000 patients, this is Dr. Fuster's study, carotid ultrasound IMT plus plaque, and looking at coronary calcium scanning, plus other testing. The first paper that came out really used coronary calcium as the gold standard and determined how other measures stacked up. So plaque burden by IMT did very, very well. Lowest tertile, intermediate tertile, highest tertile. Keep in mind these tertiles because I think they're very critical with what I'm going to talk about later. IMT had very little impact, aortic diameter and ABIs, very little impact. Sort of stunning. Remember, we used to think that any plaque in the carotids was a high-risk equivalent? Well, plaque was absent in only 20% of low-risk males, 25% of low-risk females. Ubiquitous. Age, present just as often in people 55 to 59 as people 70 to 74. And even more stunning, as Tasneem pointed out, patients had a 0 coronary calcium score. 75% of them had detectable plaque, both men and women. So we'll talk about that as well. And then coronary calcium is tracked very closely by the plaque burden. This is the quartiles of plaque burden by carotid ultrasound, and you see that the incidence of high coronary calcium scores and the presence of any coronary calcium increases in a very linear fashion, very stepwise fashion, with increasing tertiles of plaque burden, whereas IMT did not track it at all. IMT was totally flat. And for risk prediction, in preliminary results in 3,600 patients, 3D carotid ultrasound did quite well, not quite as good as coronary calcium, about the same as the CardioScore blood test. Very suggestive. If you added the plaque burden to a high calcium score here, you increase the event rate from 3.26 to 4.4, so there may be an additive effect of plaque burden. And here again is that tertile hypothesis. Lowest tertile for risk prediction, 1.15 odds ratio, increasing to 1.83, increasing to 3.63. So my take on this is that the 3D plaque analysis reveals that plaque is much more prevalent than previously thought. It tracks coronary calcium, IMT does not. The high percentage of plaque in 0 coronary calcium patients mandates that plaque be evaluated with a minimum abnormal volume and then a graded scale for a risk assessment, like tertiles or quartiles. And I do think the HRP outcomes will affect screening recommendations. This is my concept of SHAPE 2. This is not endorsed by SHAPE. It's one of the things that we're going to talk about, in which I would still exclude the very low risk, those who have 0 risk factors. I would include people over the age of 75. That's no longer an exclusion criteria. Coronary calcium or carotid plaque burden. Negative test, 0 calcium score or 0 carotid plaque. Positive test, presence of calcium or presence of carotid plaque. And redefining the risk categories as I showed you for coronary calcium. Less than 100 is low risk, period. We would then say that's equivalent to the lowest tertile of carotid plaque. Now, I'm not seriously saying that the carotid plaque at this point is ready for prime time. We have the HRP study, we have Dr. Spence's work. We probably need a few more studies to validate this. Calcium score 100 to 400, it's the intermediate risk, middle tertile. Greater than 400 or greater than the 75th percentile is the highest tertile, and we call that high risk. It's simple, it's straightforward. Also, let me point out that, as I understand it, NCP4 is going to be released after AHA for public comment, ATP4, and will presumably be officially published early next year. I can't tell you what it says because I don't know, but I've managed to eke out that one of the things that's going to happen is that the intermediate risk category is going to be lowered from 10 to 20% to 5 to 20%, and that the treatment goals are going to change. So what the treatment recommendations based upon these risk categories are, we don't know. They're going to change with NCP4. This is from Roger Blumenthal, Guidelines versus Rules. Venkman, if you saw the movie Ghostbusters, I make it a rule never to get involved with possessed people. Actually, it's more of a guideline than a rule. And this is a quote from Roger's article here in JACC. We must avoid the cognitive dissonance that often impedes forward progress and confines guidelines to the necessity of the RCT in order to optimize the care of our patients in light of the available evidence. And finally, the old Chinese proverb that everybody has seen, last slide, for patients undergoing risk evaluation, superior doctors use coronary calcium, mediocre doctors use the Framingham risk score and hope their patient is still alive when the RCT is complete. Inferior doctors are so biased that they will never use coronary calcium. Thank you very much.